we're going to continue with congenital heart defect. Um, Before we did ASD, we did VSD, and we did endocardial cushion defect. So we're going to move right along, and we're going to start with the anomalous pulmonary venous connection. So when you see the term anomalous, that means abnormal. You know that the pulmonary veins normally drain into the left atrium. So if there's an anomalous connection, that means it drains elsewhere. So, and the common place for drainage is the right atrium, but it can drain, in the upper portion of the right atrium where you have the superior vena cava entering the right atrium, or it can drain into the lower portion where the inferior vena cava drains into the right atrium. So you can have any one of those connection. You can also have what we call total anomalous pulmonary vena connection, where all four pulmonary veins drain into the right atrium, so to speak. Or you can have partial, where two may drain into the left atrium and two drain into the right atrium. So, or 1 and 3. So you can have total anomalous pulmonary venous connection. You can also have total. Let's look at total anomalous pulmonary venous connection. All four pulmonary veins connect to the systemic circulation. Okay, so what we're saying is that none of the pulmonary veins drain into the left atrium. You need some connection between the right atrium and the left atrium, so to speak, for these babies to survive. Okay, so you need either patent foramen ovale or atrial septal defect, because you have to get oxygenated blood on the left side of the heart. So you need some connection for that baby to survive. So either patent foramen ovale or an atrial septal defect, which allows, because you're draining all the oxygenated blood in the right side of the heart. So you have to get some of that oxygenated blood to the left side. So if you have a ASD or a PFO, then you'll have oxygenated blood going to the left side. As mentioned before, you can have the pulmonary veins draining in the upper portion of the right atrium, and we talk about the supracardic, where the pulmonary veins drain into the innominate veins or the superior vena cava. That accounts for about 50%. Okay, so in the upper, if it drains into the upper portion of the right atrium, in the innominate veins or superior vena cava, we call that supracardic, and that accounts for about 50%. 20% the pulmonary veins drain into the coronary sinus or the lower portion of the right atrium, so to speak. And then another 20% it's infradiaphragmatic, where the pulmonary veins drain into the portal or the hepatic veins. So just thinking, half of them is going to drain in the uppermost portion of the right atrium, where you have the innominate or the superior vena cava draining into the right atrium. And then another 20% is going to drain in the coronary sinus or the right atrium proper. And then the lowermost portion, we call that the infradiaphragmatic. That's where the hepatic vein, that's where the inferior vena cava comes in. So it may drain into the portal or the hepatic veins. That's where the inferior vena cava comes into the right atrium. And then in another 10%, you have a mix. It can be, so that's total anomalous pulmonary venous connection. All the pulmonary veins drain in areas other than the left atrium. You need some communication for survival. You need communication between the right side of the heart and the left side, usually a PFO or of ASD. Now we come to partial anomalous pulmonary venous connection, where not all four of them are draining areas other than the left atrium. So some pulmonary veins connect to the systemic circulation, but not all. You will get some probably connecting to the superior vena cava or the right atrium proper, or it may drain into the inferior vena cava. So scimitar syndrome is when the pulmonary veins drain into the inferior vena cava. That's what it is. That's what we call scimitar syndrome. Or again, you might have some draining into the coronary sinus, but not all, not all. When all of them drain, then you have total. So how do you identify this on your echo? Because, you know, this is the echo is one of the tools that's going to lead to early diagnosis. So when you're doing your echo, you have to try and identify all four pulmonary veins. Okay? If you can't see all four pulmonary veins on your transthoracic echo, then that's an indication to move on to a transesophageal echo. You have to identify all four pulmonary veins. So in the apical four-chamber view, you can see the right and left. This is supposed to be upper pulmonary veins. All right. So in the apical four, you can see the right and left upper pulmonary veins. Okay. So you know, remember, you do the pulmonary veins is where you where you do pulmonary vein Doppler. That's where you do it. So you should be able to see the right and left upper pulmonary veins, and in the subcostal four chamber, you see the right upper pulmonary veins as well. With the parasternal short axis, you can see the left upper pulmonary vein. So you have to try and identify these when you're doing your study. And then if you do your transesophageal echo, you can see all four veins. So if you don't see them on the transthoracic, then again, that's an indication to move on to your transesophageal echo. All right, so it's the apical 4 or 5 chamber view. So this one right here is the left upper, and then you have your, sorry, this is the right upper, and this is the left upper, okay? Right upper pulmonary vein, and this is the left. So I label it as lower, but it's actually upper, and the same thing. And then with the subcostal view, you can see, right, you can see it again. So try and identify these pulmonary veins. Okay. So if you don't see it on your transthoracic, then you have to, that's an indication for transesophageal. All right, we're going to move on now to PDA. We talk about PDA. What is a PDA? We talk about patent ductus arteriosus. And you have to have an idea what we're talking about. So when the baby is born, you get closure of this PDA. PDA is are the ductus arteriosus, not PDA. The DA, ductus arteriosus, is an important vessel in the developing embryo. remember when the embryo or the fetus is forming, the lungs does not function. The lungs is not, the baby is not breathing in utero. So some you need some blood flow going to the lungs. Okay, so there's a communication between the aorta and the pulmonary trunk, and that is what we call the ductus arteriosus. And it allows blood flow to the lungs because the baby is not breathing and there's no so-called pulmonary circuit. The pulmonary circuit is not fully formed. Okay, so that is how the lungs get blood flow in the developing fetus. Blood flow from the aorta to the pulmonary trunk via the ductus arteriosus. But when the baby is born and the baby takes the first breath, that opens the lungs. Okay, it opens the lungs, and blood start flowing from the right ventricle across the right ventricular flow tract into the pulmonary trunk into the pulmonary circuit, and that in itself results in a functional closure of the ductus arteriosus. So you get a functional closure, and over time it results in a anatomical closure. But that don't normally, sometimes that does not occur. Sometimes the ductus fails to close, and that's what we call failure of closure of the ductus arteriosus, and that results in a PDA. So now you have a communication between the aorta and the pulmonary circuit. So what happens is oxygenated blood flows from the aorta to the pulmonary artery because the pressure in the pulmonary circuit, the pressure in the aorta is greater than the pressure in the pulmonary circuit. So you have blood flowing from the aorta into the pulmonary circuit. Okay. Over time, it can give you similar problems to a VSD, in that it's going to cause volume overload on the LV. So the left ventricle is going to dilate, and you get pulmonary hypertension because there's increased blood flow into the pulmonary circuit. And when you listen to the patient, you get this, what we call a machine or a continuous murmur. Because you're going to get a murmur in systole and a murmur in diastole, because the pressure in the aorta is always greater than the pressure in the pulmonary circuit. So you're going to get a murmur in systole and a murmur in diastole. We call that a continuous murmur. So what are some of the signs and symptoms of a PDA? Again, anything to involve the heart. You're going to get shortness of breath, so dyspnea, dyspnea with exertion. Then if it's pretty bad, you get orthopnea, PND, dyspnea at rest. Tachycardia, the heart always tries to compensate. And one of the compensator mechanism is increased heart rate, tachycardia. And then you get the murmur, the continuous machine-like murmur. Cardiomegaly, because the LV becomes dilated. Bounding pulse, widened pulse pressure. When we talk about pulse pressure, it is the difference between the diastolic pressure and the systolic pressure. That's what the pulse pressure is. So you'll probably get a very low diastolic pressure, a reasonable systolic pressure, but the difference is larger than normal. So that's what we call a widened pulse pressure. poor growth in the baby. That's one of the reason for failure to thrive in a baby. Okay, poor growth, any type of congenital heart disease, differential cyanosis. Okay, um, and heart failure. It results in heart failure. So on your 2D echo, how do you make this diagnosis? And it's important for you to make the diagnosis in the echo lab. So in the parasternal short axis view at the level of the pulmonary bifurcation, you're going to look. So you normally will see the right ventricular flow tract, the pulmonic valves, the pulmonary trunk, and then the pulmonary trunk divides into a left main pulmonary artery and a right. But if you see a third leg, that's a PDA. Because remember we said that the ductus arteriosus joins the pulmonary trunk, okay, from the aorta. So in a normal individual, normal anatomy, you should only see two bifurcation at the pulmonary trunk. So if you see three bifurcation, then you're talking about a PDA, patent ductus arteriosus. So parasternal short axis view at the level of the pulmonary bifurcation is a good view. You can also do a modified view, we call a high left parasternal long axis view of the pulmonary artery. You should always try and do this to identify the branches of the pulmonary trunk. In the suprasternal notch, so we tell you to do this not because we want to give you more work, but you can pick up coarctation of the aorta, you can pick up PDA, so suprasternal notch view. So remember, it's a communication between the aorta and the pulmonary trunk. You can use your color flow Doppler to see, because if you're in the short axis view at the level of the pulmonary trunk, you can see this blood flow going into the pulmonary trunk. Okay, so the color flow will identify that. And then continuous wave Doppler will definitely show you that there is significant flow going from the aorta into the pulmonary trunk. And remember, it's just like a VSD, you're going to get dilatation of the left ventricle and left atrium. Let's see what we got there. All right, so this is a cartoon which shows a cut section of the heart, and you have the aorta comes up here, the branches, but the ductus or the patent ductus is a communication between the aorta and the pulmonary trunk. Okay, it's right there. As mentioned before, in the developing fetus, okay, in the developing fetus, it's an important communication because again, the lungs are not expanded, and you need blood flow to the pulmonary to the lungs. But at birth, it normally closes, okay? But sometimes it remains open, and that's when we call it a patent ductus arteriosus, when it remains open, okay? So again, your short axis at the level of the pulmonary trunk, you have to show that there's a third leg, or a third bifurcation. Put your color flow in, C doubler, okay? And you have to look for this. You get dilatation of the LV and the left atrium. All right. So now we're going to move on to coarctation of the aorta. So you guys have seen this before, but we're going to go over it again. So coarctation just means a narrowing. And then when we talk about coarctation of the aorta narrows in the region where the ductus inserts. Okay, that's where you usually get the narrowing. But we can talk about a preductal, a ductal, and a postductal coarctation. So the narrowing may be before the ductus inserts, or where the ductus is, or it can be exactly where the ductus is located, or after the ductus. And the ductus arteriosus is really close to the left subclavian vein. So sometimes we use this left subclavian vein as the marker. The reason for doing that is because the location is somewhat similar. So that's the only reason for that. All right, so that is the coarctation. So it is twice as common in boys as it is in girls. Okay, and it's common in girls with Turner syndrome. So it's fairly common in Turner syndrome. So you'll have to make the association between Turner syndrome and coarctation. So Turner syndrome, girls with short stature, web neck, mild mental impairment, and if you see the features, you can pull it up, YouTube. Once you see one case, you'll never forget it. So again, the different types, you can have preductal, that is before the ductus. So the narrowing is proximal to the ductus, where the ductus enters the pulmonary trunk, or it can be ductal. Okay, the narrowing is at the insertion of the ductus arteriosus, or it can be postductal. The narrowing is just distal to the insertion of the ductus arteriosus. Again, sometimes we use the left subclavian vein as the marker because it's usually similar location. So coarctation means a narrowing, okay? And the narrowing is in the descending aorta, okay? So the suprasternal notch view is a very good view to look for coarctation. And that is why you have to do suprasternal notch view, not because we want to give you more work, but you can pick up stuff, okay? So you can see the narrowing. So the narrowing sometimes can be very dramatic or it can be very subtle, but you have to look for it. What are some of the signs and symptoms of coarctation of the aorta? So mild cases may have no signs or symptoms, okay, until later in life. But if you have a narrowing of the distal aorta just after the arch, then it can put significant pressure in the portion of the aorta proximal to the narrowing, because blood cannot get through this narrowing. So you will have significant pressure developing before the narrowing. And it's not uncommon to see patients with hypertension in the upper extremity, and the pressure in the lower extremities are pretty low. Okay, so that's, you can get that. And then if the narrowing, if the coarctation is just proximal to the left subclavian vein, if it comes just before the left subclavian vein, then the left subclavian vein and the left subclavian artery is not going to be involved in the whole process. All right, so the left subclavian artery is not going to be involved if it comes just before the left subclavian artery. So when you do blood pressures in both upper extremities, the left and the right arm, you'll get a differential pressure. If it comes just before the left subclavian artery comes off the aortic arch, then you're going to get high pressure in the in the right arm. The pressure is going to be elevated in the right arm, and you're going to get a low pressure in the left arm. So that is a reason, one of the reasons for doing blood pressure in both arms. So if you get a differential pressure, that could be one of the reasons. Okay, coarctation. So again, mild cases may have no signs and symptoms until late in life. Other cardiac defects that is associated with coarctation of the aorta, a bicuspid aortic valve. So a bicuspid aortic valve sometimes associated with coarctation of the aorta. VSD sometimes is mitral valve abnormality, sometimes associated with it. And again, any pathology that involves the heart, you can get shortness of breath. Okay. Poor appetite, failure to thrive, dizziness because of the increased pressure, syncope because of increased pressure, chest pains. And patients sometimes will tell their fatigue, headaches because of the increased pressure, have headaches, hypertension in the arms, low pressure in the legs. We'll talk about a radiofemoral delay. So if you feel the femoral pulse and the radial pulse, you'll feel that there is a delay because of the decreased blood flow into the distal or the descending aorta. So those are some of the signs and symptoms. So, but the echo is crucial in making the diagnosis. When you use your two-dimensional echo, again, if you look at the high left parasternal view or the suprasternal notch view. Suprasternal notch view is crucial. You have to know what your normal descending aorta Doppler looks like. Okay, because sometimes you can't, visual inspection alone is not good, because I mean there may be a small narrowing in the descending aorta, but you just can't see it. So that's why you have to put color. You put in your color. Your color is going to identify if there's turbulence, because if there's a narrowing, you're going to get turbulence. You're going to see abnormal blood flow, turbulence. And then you put your continuous wave Doppler in. You put your PW in first, and then if there's significant narrowing, you're going to get increase in velocity. You're going to get ALIS in. Then you put your CW in, and you have to look at the velocity. Okay, remember the velocity. Normal velocity is probably 1 meter per second. If you start getting 2 meters per second and you get more than that, then you have significant narrowing and increase in the velocity. And then the pattern for the continuous wave, the so-called sawtooth pattern, almost always going to clinch the diagnosis. Okay, and color flow, you get turbulence, ALISing. So this is what the normal suprasternal notch view. You should always do it. So this is in systole, you get a flow usually about 1 meter per second. Okay, almost no diastolic flow. No diastolic flow almost. Okay, you get a nice pattern like this. So your PW first. Okay, and then if you see something significant, you put your CW in. You're going to get increased velocity. You're not only going to get an increased velocity, but you're going to get a diastolic flow. We call this a sawtooth pattern. Okay, so you have to know what your normal looks like. You have to know what normal looks like to determine, when it's abnormal. So this is a so-called sawtooth pattern, which clinches the diagnosis of coarctation of the aorta. Significant increase in the velocity. It's your suprasternal notch view. Okay, this is the ascending aorta right there. This is the aortic arch. Okay, and the descending aorta now comes down. You have to know the branches. Okay, you have to know the branch that comes off the aorta. Okay, this is your left subclavian artery. This is the left common carotid. The nominator is someplace over here. Okay, so usually if you have a post ductal, it comes after the left subclavian, so it's going to be here. But as again, you cannot see that there's a narrowing, so that's why you have to put your Doppler in to determine if there is a significant narrowing. So it can the narrowing can be post-ductal, or it can be right at the left subclavian, or just before the left subclavian. Okay. All right. We'll blow it up. Okay, so you get the velocity is increased. It's no longer 1 meter per second. This is 4 meters per second. Very high. And then you have a persistent diastolic flow. Okay, remember what the normal looks like. This is what the normal looks like. Nice, crisp systolic flow, nothing else. So you have to know what the normal looks like. Okay, again, so this is your so you have to again you have to know the branches of the heart. So this is the right pulmonary artery, and then below that you'll have the left atrium. So the RPA is right there. All right. Let's okay, let me see if we should do. All right, we'll go on to Epstein anomaly. So in any exam that you're going to do, you're going to see Epstein anomaly. So you have to know what Epstein anomaly looks like, and you should be able to make that diagnosis or determination in the echo lab. So Epstein anomaly. So when you see something, say anomaly, anomalous, whatever, it's abnormal. So Epstein anomaly, the septal leaflet of the tricuspid valve is displaced towards the RV apex. So the septal leaflet is very, very low in the right ventricle. So there's almost no right ventricle. There's a huge right atrium and almost no right ventricle. Okay? And not only that, the right ventricular myocardium is usually abnormal. Epstein anomaly is very classic, and you should be able to make the diagnosis. Again, the septal leaflet of the tricuspid valve is displaced towards the RV apex, and these patients will have significant amount of tricuspid regurgitation. Okay? What are some of the other abnormalities associated with Epstein anomaly? It is associated with ASD or a PFO in 50% of the cases. So half of these patients are going to have atrial septal defect or a patent foraminal valley. The so-called Wolff-Parkinson-White syndrome, 50%. Wolff-Parkinson-White syndrome is just an abnormal electrical connection between the atrium and the ventricle. So the patient will have a bypass tract. So if you remember the conduction system, Conduction system is orderly system, but when you have Wolff-Parkinson-White syndrome, there's an abnormal tract connecting the atrium and the ventricle, which bypasses the AV node. So, and these patients can have very rapid heart rate, and sometimes they can develop sudden cardiac death because of this. And when you look in the ECG, you have the so-called, what we call a delta wave. So delta wave will tell you that the patient have Wolff-Parkinson-White syndrome. So Epstein anomaly, 50% going to have ASD, PFO, 50% going to have Epstein anomaly. On the ECG, you get this right bundle branch block pattern and first degree V block. All right, all right, so this is the left side, the right side. This is actually the tricuspid, the septal leaflet of the tricuspid valve is way down here. So this is the right ventricle. This little area is the right ventricle. So you have a huge right atrium, okay? All right, so if you see anything looking funny like this, Epstein anomaly. So the septal leaflet of the tricuspid valve is apically displaced. And we're going to talk about a displacement index later on. So if they want to be a little bit cruel, they'll put that on the exam. And all right, so you have a large right atrium, a small right ventricle, and then this displacement index of more than 8 millimeters per meter squared. So basically what you do, this displacement index, you just measure the linear distance between the septal leaflet insertion of the tricuspid valve and the mitral valve and divided by the body surface area. So basically you measure the distance between the septal leaflet insertion of the tricuspid valve and the mitral valve. Okay? So if you say you get 20 millimeters, then you get the body surface area of the patient. In order to get the body surface area, you need the height and the weight. And then you just divide that distance by the body surface area and you'll get the displacement index. So more than 8 millimeters per meter squared will make the diagnosis. You'll get tricuspid regurgitation, ASD, PFO in 50% of these patients. Okay, so small RV, huge right atrium, Wolff-Parkinson-White syndrome. Okay, so it's classic. If you go on any of the websites, you'll see that. All right, so we're going to stop here.